organized by the CEPEC platform, the Canadian Critical Care Comparative Effectiveness Platform. And one of the interventions we're studying in a trial that's just gotten started in Canada is the use of platelet transfusions in the peri-procedural setting. So great pleasure to introduce our two speakers today. Jeannie Callum is the Director of Transfusion at the Kingston Health Sciences Centre and Professor of Medicine at Queen's University and the University of Toronto. And her main interest is in clinical trial and transfusions, and she discloses that she's not a fan of albumin. And also her co-presenter is Dr. Alex Maynard, who's Vice President of the Canadian Association of Interventional Radiologists, who's an interventional radiologist at Queen's and who advises that he tries to stay out of trouble with Dr. Callum in his role in prescribing platelets. All right, we'll get started. Thanks very much, Jeannie. I think you're going to lead us off.
Perfect. You just, you can hear me and you can see my slides there. Perfect. Okay, so Alex and I are going to present on platelet transfusions for patients in critical care and when they have their trips to IR for procedures. So our disclosure, so I get research support from Canadian Blood Services that make platelets, and I was on a guideline panel member for the ABB guidelines as well as the CAR guidelines. But probably the biggest disclosure is I'm a hematologist. All of our platelet counts have platelet counts less than 10, and I'm completely desensitized. And I have to disclose that I've done lumbar punctures because I forgot to check the platelet count and it was undetectable, and then nothing happened. And I've done that many times. But on the flip side, I see a lot of serious transfusion complications, including transfusion-related fatalities. And so I'm a little bit more gun-shy about transfusions than maybe somebody else. And for Dr. Menard, he's the lead for the CAR guidelines, but also he does a lot of low-risk procedures in IR, which led to the IR guidelines, and which you really don't need to do a platelet count, and these procedures have less than a 1% bleeding risk. So transfusion doesn't make a lot of sense for many of them. So when I think about decision-making around platelet transfusions, these are the things that I think about in my decision-making. So I consider the risks. I think a lot of people think, oh, there are no risks to platelet transfusions, so there's only benefits, but this is very not true. And I'm going to show you the data for that. I think you need to understand that we have this huge reserve for our platelet protection. Most of us are sitting at 280, but you really don't bleed until you're below 5. And so patients can tolerate very low platelet counts before they bleed. I'm going to show you the what's been said in the most recent evidence-based guidelines. There are recommendations. They're all based on very low quality data. And so obviously that calls for more trials. And then I'm going to just have one slide about when we just basically almost never transfuse platelets, since you need to have that top of mind. And then Alex is going to talk about the perspective from IR about like, what does the data tell us? And then I'm going to show you, we looked in the Ontario Gemini data, so you can see how compliant we are. You're not going to be surprised that we're not compliant, and we have very variable practice hospital to hospital. And then just a couple of slides about the T4P trial. So the most important message is we don't know when to transfuse platelets in critical care, and that's what this trial is trying to answer. We're also concerned about the risk from the platelet transfusions. We don't understand what that risk is and why we're seeing higher death rates with more platelet transfusions, but that's something you need to keep top of mind. Also, we're also worried about bleeding because bleeding complications are terrible for patient outcomes. And so we need to basically balance on this tightrope. This is also very costly. It costs about $1,400 per platelet unit. And so this is a very expensive intervention. And so we need better data for such an expensive therapy. So in terms of risks, these are the most important risks that I think a patient should know before you embark on considering a platelet transfusion. So the first is alloimmunization. That alloimmunization could lead to some pretty serious pregnancy complications or becoming ineligible for solid organ transplantation. Infusion reactions are really, really common because there's a lot of cytokines and histamine on our platelet transfusion products. They're considered minor, but they're not so minor in their downstream consequences because 25% of those patients get, imaging, they get, blood cultures started on antibiotics. And so there are downstream consequences that aren't great for those patients just from minor reactions. The risk of transfusion-related acute lung injury has dropped to 1 in 10,000, but we haven't been able to get it any lower despite the fact that we've made our blood products as close as we can to being female-free to get rid of the HLA antibodies that cause TRALI that are women produced during pregnancy. And then circulatory overload, as well as anaphylaxis. We did create a chart just for platelet transfusion risks in the CAR guidelines to put them all in one place. So I'm not going to go through this, but we have a good reference should you want to review that in more detail. In terms of allergic reactions, you shouldn't be surprised about allergic reactions because our donors are taking a cocktail of medications when we do drug testing on them. And so when you're giving a platelet transfusion to a patient with allergies, you need to make the assumption that your platelet product has these. Our platelets are now made from a pool of 7 donors. So chances are there is a drug in every single platelet pool. Okay, and then we have this other thing that we don't understand, and we see a concern for harm in 3 randomized controlled trials. And I'm just going to go through these very briefly. So the first is patch, done in patients who were on antiplatelets with an intracranial hemorrhage. Planet 2, which were preemies with in ICU, obviously high rates of intracranial hemorrhage. And then there was an RCT in ICU for patients with dengue fever. So in the patch trial, they randomized patients to platelets or just standard of care no platelets for their ICH on an aspirin or another antiplatelet. And you can see there that patients who got platelet transfusion had worse disability score. And so you can see there in the purple, the light blue, and the blue for moderately severe, and death were higher compared to nothing. And we don't understand why we're seeing this death signal as well as the disability signal. Similarly, in a completely different population of premature neonates, when they were randomized to a low threshold of 25 compared to 50 to try and prevent intracranial hemorrhage, the death rate was higher in babies, and we don't understand why that is. And then lastly, in dengue fever, this was a randomized controlled trial of almost 400 patients randomized to platelet transfusions or no platelet transfusions. You can see there was a slight non-significant reduction in bleeding with platelet transfusion, but offset by an increase in transfusion reaction and a lot more transfusion reactions than we would normally see. And perhaps because these patients are so inflamed that the additional cytokines in a platelet bag is enough to tip them over. And so, but clearly not a huge benefit. Okay, the next thing before I talk about the guidelines was I wanted to explain when patients with thrombocytopenia bleed. And so this is data from 1962. So we've known for a very long time that people don't bleed until their platelet count falls below 5. But it's hard to trust a 1962 paper. So it was good. Cheryl Slichter from Seattle replicated this in a randomized controlled trial. And this was a subsequent paper out of this trial, which was a dose-finding trial. So this trial told us what was the right dose of platelets that we're supposed to be using. And you can see there again, people didn't bleed anymore, whether you were above 50 versus above 6, but it's below 5 that we start to see that bleed. And Cheryl Slichter went on to do a very famous experiment where she gave autologous radiolabeled red cells to hematology patients that had low platelet counts and then collected their stools to find out when did they start leaking radioactive red cells into their gut. And that again was below 5, reaffirming that even though we run platelet counts of 280, you don't need a lot of platelets to stop bleeding. So obviously then you might say, well, why aren't we transfusing platelets at a platelet count of 5? And that has not been able to be possible. We can't even do trials because our instruments are not sensitive to divide people into people that are above or below 5 consistently. So those trials aren't really possible. But the hematology community did do 2 randomized control trials. This is just one of them. The other one was done in Germany, and I'm not going to show you the data because it showed the same thing. They randomized hematology patients to getting prophylactic platelets versus no prophylaxis. And there wasn't a huge difference in the bleeding rate. It wasn't statistically significant, but a trend towards a little bit lower bleeding risk with prophylaxis. But it was a very minor difference. And so we still continue to give prophylaxis because both trials showed the same sort of trend. Okay, so what do the guidelines recommend? So we have two recent guidelines to kind of tell you what to do. So the first one's the ABB ICTMG guidelines from 2025. And these are the ones that you might want to know about in a critical care population. So if you have somebody that's in the critical care unit, they have hyperproliferative thrombocytopenia, say from their chemotherapy, you would give them platelets if they're less than 10, so single digit, generally based on the morning platelet count, and it's just one platelet a day. You don't chase the platelet count and just keep checking and transfuse 6 if they don't respond. It's really just generally those trials for once a day. If they're autologous stem cell transplant, you're okay to give that no prophylaxis. Check the patient every morning. Are they bleeding? Yes, give a platelet. No bleeding, no platelet. For people with consumptive thrombocytopenia like DIC, less than 10. Please note that 2 of these are low to very low certainty of evidence. So we just basically don't have a lot of data for either of those. For procedures, they met a recommendation for lumbar puncture, consider a platelet transfusion below 20. For a compressible line, consider less than 10, but moderate to very low certainty of evidence. For procedures, a low-risk procedure less than 20, high-risk procedure less than 50. Again, very low certainty. This is just based on expert opinion. It's not based on good randomized controlled trials. And then for people going for operative procedures to the operating room, use a platelet count of 50. And then based on that patch study that showed that increased risk of worse neurological outcome and death, they recommended with low to very low certainty. If you have a patient on aspirin with an intracranial hemorrhage not going to the operating room, platelet count above 100 to give a transfusion. This guideline did not say if the platelet count is below 100 to give a platelet transfusion. They did not address that situation. So there is currently in the ABB guidelines no recommendation of what to do if you have an intracranial hemorrhage and the platelet count's below 100. I have an opinion, but that's not based on evidence. And then in the chest intensive care guidelines, very similarly said in critically ill patients, with this caveat at increased risk of bleeding, undergoing a central line or an art line, don't give platelet transfusions. They don't even talk about numbers. Again, very low certainty of evidence. Thora and paracentesis, again, don't do it, but very low certainty of evidence. But here's the difference compared to the ABB guidelines looking at the same evidence. In critically ill people at increased risk of bleeding, consider a platelet transfusion for a lumbar puncture if the platelet count's below 40 to 50, but very low certainty. So they didn't define in their article or in their guideline what is with increased risk of bleeding. So I emailed the primary author, what did you mean by this? And the recommendation was to use some sort of validated score that was associated with bleeding. But I don't think that that was well communicated for this guideline. There are also guidelines to do with if you're a critically ill patient, you're on anticoagulation for a recent clot, what to do if you're also thrombocytopenic. And this comes from the ISTH, which is the International Society for Thrombosis and Hemostasis. If your platelet count's above 50, go full steam ahead, full anticoagulation. If you have a high-risk clot, so you have a symptomatic PE, proximal PE, proximal DVT, recurrent progressive thrombosis, okay, transfuse platelets to greater than 40, and continue full dose anticoagulation. But if it's not a high-risk clot, just look at the platelet count every morning, below 25, hold the anticoagulation. 25 to 50, give half dose. Above 50, give full dose, and adjust your dose daily. Okay, and so before I turn over to Alex, when do we almost never transfuse platelets? It's everything that has those short forms with 3 letters, where we're really cautious about giving platelet transfusions, either because they often don't work, they just don't increase the platelet count, so they're not very useful, and so they have all the side effects with none of the benefit. But also in numerous observational studies, they suggest that there's a possible increased risk of clots as well as in-hospital mortality when platelet transfusions are given to these patients. So we have a lot of nervousness about giving platelets to these patients. Okay, so from my perspective, the risks of platelet transfusions, remember there are risks. There are even risks that we don't even understand, like what we're seeing in the patch and the Planet 2 study. People spontaneously deplete at 5, so a platelet count that's, sitting between, 10 to 50 is a pretty decent platelet count for most people. The evidence-based guidelines, they recommend what to do, but they're all based mostly on low or very low certainty. So we definitely need more studies to get us out of this gray zone. And hopefully that's what T4P is going to help us with. And then lastly, just please don't transfuse those people with those 3-letter short forms because we're concerned about a death signal. With that, I'm going to turn it over to Alex. And Alex, I'll just flip through the slides as you tell me.
Yeah, I'll let you drive. Thanks, Jeannie. Thanks for the invitation to present. Here in Kingston, I have a very good working relationship with my critical care colleagues, so it's quite an honor to be speaking to this group. Hopefully, I can give a bit of an IR perspective on how we see the evidence regarding this, and maybe not bring some clarity to all of this, but at least a different viewpoint. Thanks, Jeannie. Next slide. So I'm just going to throw a case out there to kind of show how, depending on where you work and which specialty you're at, and what kind of practice you have, you might see this problem differently. So this is a very sick, clearly postpartum patient that's in a bit of a nightmare scenario. The liver's failing, INR is 8, the platelets are completely gone at 8, and ICU is struggling at establishing good venous and arterial line access. So if we're going to do a central line and arc line in ICU and the operator is an intensivist, are we going to transfuse blood products? Are we going to transfuse platelets? What if this was performed in IR by interventional radiologists? Are we going to delay getting this procedure done, waiting for blood products, or is it safe for an interventional radiologist to go ahead with this? So I'll give my own perspective on this a bit towards the end of my slides. I was very lucky to chair the recent CR and care guidelines, and this was a combination of both diagnostic and interventional radiologists, where we're trying to update evidence since 2019, just adding evidence since the 2019 SR guidelines. Jeannie was one of our hematologists on the panel, and we had 2 other excellent hematologists to help us guide our way through. And these guidelines are very, very simple, and they're very practical and easy to implement within all hospitals. Next slide. The hematologists are very good at giving us these major principles, which is that, despite all our attempts at quantifying bleeding risk with blood tests and platelet levels and cirrhosis and things like that, the biggest factor in having a patient that's going to bleed from a complication is a patient that's had a previous bleed from a procedure. And that is probably the number one thing that we should all be asking our patients before we do anything to them. That laboratory tests are very limited in predicting. They can predict somewhat, but they're not a very good test at predicting bleeding risk. That overall, there's harms when you discontinue a patient's antiplatelet and anticoagulation medication. I do acute stroke therapy. I do stroke thrombectomy, and I've had many patients that I've had to do this procedure on because for a dental procedure, they had stopped their apixaban. And I can tell you that the overall result of their stroke, despite our intervention, was not great for the patient. Complication rates for image-guided procedures when they're performed by interventional radiologists are very, very, very low. I guess my analogy here is that I have broad medical knowledge, but if I was in ICU, my ability to adjust vents is essentially like FiO2, right? Like I just don't have the knowledge and experience that you guys have on all the other medical knowledge. And in radiology, our degree of experience at accessing with a single poke, a clean poke, a perfect needle guidance on every case, that's just what we do. That's what we're trained in doing. And so overall, our complications rates are very low. And when this is a bit like applying statistics to screening exercise. If you have a disease with a very low rate of disease, doing science on it becomes very, very difficult from a statistics point of view. There are complications associated with transfusion. Jeannie did a great job presenting that. And that overall bridging is not a good idea when you're trying to do a procedure on a patient. It's very rare that patients on like mechanical mitral valve might be like the one that's most important. And so the way the interventional radiology world and the radiology world we try to approach this is that we classify our procedures into low risk and high risk and try to keep it simple. And then we have essentially 2 kinds of patients. We have patients with normal liver function and we have our chronic liver disease patients. For the intent of what we're talking about today, essentially we're talking about low risk procedures. And overall, we care about platelets that are less than 20, but we don't even screen. And we don't stop Plavix, we don't stop aspirin, and we only correct if it turns out that there was a recent CVC, but otherwise we don't even screen these patients when we're doing low risk procedures. Next slide, please, Jean. So how did our panel decide that it was going to be low risk? The bleeding risk should be less than 1% and really should be closer to 0.1%. These are procedures where you can compress and control the site until you can find alternatives to maybe correct your low platelets or correct your improper INR or correct for the anticoagulation. And also procedures for which there is evidence that it is low risk, that doing these things are quite safe. This is a list of procedures which were attributed to low risk versus high risk. And the low risk list is rather long and includes pretty much any MSK intervention, thoracentesis, paracentesis, large bore chest tube insertions, even tube insertions into what in the past we would have considered high risk, but as long as we have good control, a suprapubic catheter insertion would be considered low risk. For the intents of the procedures we're talking about today, central line insertion, dialysis line insertion, art line insertion, these would all be considered low risk in our world. So here's an example of a couple of studies that we looked at and roughly what is the signal that's happening in the world of interventional radiology. So the first paper is coming from Scott Teratola, who is a very strong academic IR at Penn, and Penn has a very good IR department. And they just retrospectively look. Their complication rate is around 0.1%. And I think most, at least academic IR departments in the country would say that, yeah, a grade 3, 4 complication hemorrhage from dialysis line insertion will be in the 0.1% kind of range. Another study that was published in 2016 that was looking at complication rates when the patients were on warfarin, when they were on Plavix, when they were heparinized, and you compared that to a control, had the same bleeding rate, which was in the 0.3 to 0.45%. So a couple of things that are happening here. One is the bleeding rate is very, very low. And secondly, what we would normally associate as bleeding risk factors, such as being heparinized or being anticoagulated or being on antiplatelet, does not change that baseline much, if at all. And so these are the sort of evidence we utilize to say, yeah, dialysis line insertions performed in radiology department are considered low risk, and we really are not worried about platelets of 25. We're just going to go ahead and do it. So leading to the PACER study, I'm just going to give a few comments on this, and I think Jeannie would like to jump into. First off, if you look at the grade 3, 4 complication on the PACER study, in the transfusion group, which was the better of the arm, their complication rate was 2.1% for grade 3, 4. That is a high complication rate in my world. And 5% for the no transfusion group. And when you dig deep into the patient study, there's a few items I would like just to caution about. One is that to be an operator in the study, you needed to have performed 50 ultrasound guided line insertions. In an IR fellowship, you should have achieved that by your third week of your IR fellowship. My residents have achieved that by their 8th week on their IR rotation. And so there were probably some proceduralists in those ICU studies that didn't have the same degree of experience as other ICU physicians who have had like hundreds, if not thousands, of line insertion experience. And you could maybe estimate that there would be some higher complication rate with lower experience. The other thing I would be careful about in the study is, so it's Dutch, and the Dutch, I do know, practice very much like Canadians in their healthcare system, or at least in my world, at least in the world of interventional radiology. And there was a significant amount of these lines that were tunnel dialysis lines. In Canada, in the places that I know of, tunnel dialysis lines are almost always performed by interventional radiologists. It'd be unusual for a ICU physician or a nephrologist to place a tunneled line within our Canadian healthcare setting. And so I wonder how were the operators clarified? If you dig deep into the PACER study, the patients that had tunnel dialysis line, which is a higher risk procedure relatively, had actually less complication rate than the patients that had tunnel dialysis lines. All of that is to say things are a little bit muddy in this study, and I think they tried to make it very practical and they may try to make it easy to recruit. But I think we have to be careful in how we interpret that. Jeannie, did you have something to add on this?
No, I was just going to say that despite having, relatively large number of patients, they didn't answer the question. So we still really aren't 100% clear whether or not patients in the ICU with platelet counts between 10 and 50 would benefit from a platelet transfusion. We still haven't clarified what the risk benefit. So it just calls for not just more trials, but it's going to have to be a very big trial to answer that question. And I don't also think that a hematology patient is the same as an ICU patient. One of the criteria for bleeding is you had bleeding and then you needed a red cell transfusion, but our hematology patients get a red cell every day, every other day. And so a lot of those patients would meet that criteria, but the transfusion wasn't for the bleeding. So I'm not always so certain about this hematology outcome, but still, it leaves us with lots of gray that we have to clarify.
Just separately, if you look at, what are complication rates in our high risk procedures, so if you look at liver biopsies, if you look at the old SR guidelines where we want platelets greater than 50, the bleeding rate back then was around 3.4% for liver biopsies. And then if you took the patients that had platelets above 25, so in that 25 to 50 range and INR between 1.5 and 2.0, the bleeding rate was actually lower at 1.6%. Again, our ability to predict here is quite low. I think there's a bit of a interesting bias that happens in this study, which is that they look retrospectively, and as the guidelines were evolving, and as training was improving, and as our imaging guidance was improving, and our technique was improving, we were more and more comfortable doing these with patients with less than optimal coagulation profiles. Hence, probably why the complication rate for what should be a higher risk patient was actually lower. And I can tell you that, I've been practicing this for 18 years, and my ability to be safe in the IR suite is not, you can't even compare it to, the days when I was a radiology resident or when I was a fellow. Our equipment is just that much better. Regarding lumbar punctures, these are incredibly low risk. I'm quite convinced of this. We went deep into this, and Jeannie was actually leading the lumbar puncture in our panel. We're talking about the 0.1%, if not lower, in terms of risk of spinal hematoma. We did our own review here in Kingston, and we found one reported case of spinal hematoma, and I struggled to find it on the MRI. It was so small, we're talking about a millimeter size, not clinically significant, incidentally discovered spinal hematoma, including patients that were at high risk. There are observational studies for over 300,000 patients. Since the complication rate is so low, you can't really do a randomized control trial on this. You would have to recruit an impossibility of patients at an incredible cost to do this properly.
And Alex, to say that patient with that barely visible spinal hematoma had a normal platelet count.
Yes, of course.
Yes.
So in the CR care guidelines, which are available, they're open online. We do summarize essentially all the lumbar puncture trials, and that I'm quite confident about, that this is a very low risk procedure, and you can perform this in patients with platelets of 21 and not have significant complication.
All right. So we had the incredible opportunity to look into the Gemini Medicine data set that is run by St. Michael's Hospital in Toronto to look at the transfusion practice in a retrospective but large data set. So in this data set, we were able to look at almost 57,000 platelet transfusions given to nearly 18,000 hospital admits with a platelet transfusion compared to no platelet transfusion, to look and see how close were the platelet transfusion decisions aligning with guidelines. And you can see here that on the left is the median platelet threshold before the platelet transfusion by hospital site. And you can see there was a huge statistical difference between the upper and the lower arms. In addition, on the right there, guideline compliant, there was a lot of hospitals with very high non-compliance rate, but also there were 3 hospitals that were running around 15%. And so setting like a new target of where maybe we should be all targeting our appropriate transfusion rates. So 1 in 4 non-compliant with guidelines is super high. And I think the lack of data is driving some of this variable behavior. And you can see the variability is for both academic and community sites. But if you looked at where the T4P is enrolling patients, which I've starred there with a blue arrow, these are patients who had platelet counts between 10 and 50. They were bleeding or undergoing some invasive procedure or were anticoagulated. It was 16,000 platelet transfusions. Those platelet transfusions are about $22 million. And we have no idea in that zone whether we should be transfusing or not. So I think that this trial is really, really important to really kind of assess where are we spending money in healthcare and are we actually benefiting or are we harming patients? Okay, so can the T4P improve our decision making? So we included just a few slides about the T4P trial that's being funded by CHR and co-sponsored by the Canadian Critical Care Trials Group and the Canadian Transfusion Trials Group. And members of this team are online today to answer questions for you. So this study is determined the optimal platelet threshold for people undergoing low to moderate risk invasive procedures in the critical care unit. So these are critically ill people with platelet counts below 50, requiring at least one low to moderate, which must be every single patient that's in the critical care population. At our center, what we did was we had our IT create a dashboard that you can just click a link and it shows you everybody in the ICU ranked by their platelet count to make it pretty easy to identify these patients. And these patients are being randomized to different thresholds of 10, 20, 30, 40, and 50 for their entire stay in the critical care unit, with the primary outcome being 90-day all-cause mortality. I think using mortality as the outcome is really, really important because of the signal that we're seeing in things like the PATCH study and the Planet 2 study. So this is open label, randomized Bayesian adaptive trial. This is very important. We don't want to stop this trial until we really have a very clear indication of what is the right platelet threshold for our patients. They will be randomized 1:1:1 to each of those platelet thresholds for the duration of their stay. Here are their inclusion criteria, which is basically everybody in the ICU with a platelet count below 50. There are some exclusion criteria, so ongoing major hemorrhage, intracranial hemorrhage within 72 hours, contraindication to platelet transfusion, like those things with the 3-digit TTP, HIT, etc. Acute promyelocytic leukemia, and that's because we have higher platelet thresholds for those patients, people that refuse blood transfusions, imminent death, already in the trial, or greater than 72 hours from meeting the inclusion criteria. These are just some examples of some of the procedures for the patients that are already enrolled in the trial, things that they're having done. And you can see there that the most common procedures being done were central venous catheter insertion or removal, arterial catheter insertion were the most common things that were being done. But it was a whole, smorgasbord of different procedures. The blood banks within these centers are being helpful in terms of putting their randomization strata into the blood bank LIS to make sure that we have good adherence to the trial. So in terms of co-intervention, other blood products, TXA, anticoagulants, everything else is left up to the treating team. It's a very pragmatic trial. Platelet administration follows local guidelines, obviously, if there's, either active bleeding or a high-risk procedure. So the threshold only applies to those low to moderate risk procedures like lines. The primary outcome is the 90-day mortality, but lots of different outcomes are being tracked to make sure that we're monitoring for the complications of transfusion, possible benefits of transfusion in terms of bleeding, looking to see whether or not there's a thrombosis signal with platelets. A platelet that's in a plastic bag is not like a platelet that comes out of a regular human. They're very activated. And so we're obviously concerned about their thromboembolic complications. Canadian Blood Services and Héma-Québec both supported this trial and put in a very strong message that it's really important that people adhere to the protocol. That's the only way to really answer this question so that we can have stronger recommendation in evidence-based guidelines. Okay, so with that, I'm going to stop. And here are all the people that are involved in this study. Should you have any further questions? And we're happy to take questions. And lots of the people from the trial members, and I can see there's lots of transfusion medicine people on the line too. Um, uh, and we'd love your comments as well.
Uh, Thanks so much, Jeannie. That was and Alex, that was terrific. Uh, um, Happy to take questions. You can put them in the chat or just unmute and feel free to raise them. Jeannie, maybe one thing I'll start off with is that um, you you presented pretty compellingly the case against platelet transfusion, and yet we know that that's not reflected in practice. And in fact, there's a clear need for the trial. We don't want people to come away from the webinar convinced that platelets of 5 is the transfusion threshold. Can you speculate or from the literature comment about why you think that a quarter of platelet transfusions isn't guideline compliant, or what's going through clinicians' minds, do you think that's motivating the need for this?
Yeah, I think there's a some belief that people need platelet counts of 50 to do low risk procedures. So we see that very commonly. When I came from Sunnybrook to Kingston, all of a sudden we had people saying, no, to do an LP, you need a platelet count of 100. So there's still a big belief that you need much higher platelet thresholds for procedures. I think if someone's going to the operating room and say they're just having, I don't know, packing removed, there's no blood loss, but they want a platelet count of 50 because they're going to the operating room. Instead of thinking we're almost having a spinal cord reflex and doing that. The other thing is we see a lot of platelet transfusions and the hyperproliferative thrombocytopenia between 10 and 20. I'm not sure if that's because people understood the guidelines. I'm supposed to give a platelet transfusion to prevent them from going below 10, but that's not what the trials did. They gave the platelets when they were below 10. Or whether or not they think because they're sicker and they're in the intensive care unit, they need to bump them a little bit higher because they're sicker. They have a lot of lines in, they have an ET tube in, there might be a little bit of blood in the ET suctioning. And so they're like, I'll just err on the side of caution and transfuse if they're below 20. So we see a lot of that. Even in our hematologists. So I'm not blaming critical care physicians because I even see that in our hematologists. Well, it's 11, it's trending down. Why not give it today instead of tomorrow? That kind of, but maybe they might recover, or it might be 11 again tomorrow. Yeah. The
Great.
hospitals with the highest, performance were really high performing transfusion hospitals for red cells,
Mhm.
as well as platelets. So, it looked like some centers are on top of their transfusion activity, and that results in good performance across the board for platelets, plasma, and red cells.
Mhm. Terrific. Alex, we're so grateful to have IR on board on this trial, and your guideline has been really timely. I think I'm interested in um, sort of your perceptions of what IRs think about the guidelines that you've put out, and if you think current practice is quite different from what the recommendations are, or I think there's been a huge spread. You might have done some work on that, or there might be other work um, that would form that question.
Um, I think the best way for me to answer this is so in general, we're not modifying a whole lot the SIR 2019 guidelines, which was the big change in our practice. We're just refining it a little bit. And overall, in interventional radiology, especially within tertiary or quaternary centers and academic centers, there's really very little resistance to these guidelines. If I've essentially since we've published these and we've been trying to promote them, I've had a handful of you guys are being too dangerous to "Hey, you guys are being too conservative, which tells me we're close to the reasonable point. Um, I think in general, the problem we're facing in radiology is the difference between IR and diagnostic radiology, and low risk procedures are often shared between these two groups. And as an example, here in Kingston, I would have neuroradiologists that were resistant to doing a lumbar puncture in someone with platelets below 50, despite all the evidence that we would throw at them. And one of the impetus of doing a joint two society guideline was to allow a whole discipline to operate more homogeneously across the country.
Okay, great. That's helpful and actually important for us to think about too as we implement the T for P trial.
And
Um,
Alex, yeah, I remember there was a lot of discussion about the lumbar puncture. That was like a real sticking point for the community consultation. I think that's one thing that really people are still stuck on, despite being very good evidence that there's.
Yeah, I'm not sure. The irony is like if you do an image guided lumbar puncture, like man, like it's easy and you just get in and like it's so safe. As opposed to a bedside lumbar puncture. And the evidence that a bedside lumbar puncture gets no complication is very deep. And so I think there's things that get built into the culture of a discipline that gets very hard to beat. And I'll just give a little anecdote around that. Jeannie must have been on day two of her practice in Kingston when she called one of my colleagues to say, "Why are you transfusing this patient?" And my colleague said, "Oh, well, according to the SIR 2013 guidelines." And she's like, "Well, you're right, but have you heard of the SIR 2019 guidelines?" And he hung up the phone and he says, "Guys, we're behind the times. We need to wake up and catch up with the times." The SR 2013 guidelines got really ingrained down to the level of the Royal College. Like people who are training residents, just say 50. Whatever they ask at the Royal College, just say 50, and you'll be considered safe. And so changing that, especially when you got trainees that are like burning that into their mind for the Royal College exam, it takes a lot of time.
Great. We have a couple questions. I'll start with Johnny Mack.
Hi, thanks a lot. Thank you both for a great overview of the literature and going through this. I would say, like, in terms of kind of people not updating what their practice is, like, I'm still struggling. At two hospitals I worked at, I had struggles with hematologists not transfusing at a platelet count under 20 for patients with a fever, with the belief that that kind of improves things despite the TOPS and WANT trial, et cetera. So, pretty sympathetic to that. I was curious about just thoughts and comments on the choice of 90-day mortality as the outcome for the 4TP trial. Um, I just kind of wonder, like, is it reasonable to think that a low risk bleeding procedure will result in death, and if platelet transfusion will kind of shift the needle one way or the other on that? And given that, and expecting that it may be kind of a negative trial because of that, is it going to influence? Is it going to be able to influence practice? Because people might say, well, I'm not really transfusing a platelet because I'm worried about the patient dying from this. I'm worried about them bleeding and not necessarily expecting that a low risk bleeding procedure is going to, like, bleeding from a low risk procedure is going to ultimately result in their death.
Yeah, that's a great question. Maybe Francois, maybe you can address that, and maybe Donnie and Jeannie can comment as well. There's a bit to
Uh,
unpack there. Yeah.
any of us, any of us could answer that. So I think that is so any of you add to what I'm about to say, but I think that's actually one of the unique strengths of the design, and this was before we Canadians had input on the trial. But the issue is that if you only consider the bleeding risk, you only consider the way or the ways in which platelet transfusions may benefit, and you completely ignore the ways in which platelet transfusions may harm patients. And so the focus on mortality isn't really intended to, it doesn't mean or doesn't say or communicate that you're giving platelets to save a life. Clearly, when we prescribe platelet transfusions before a bleeding risk procedure, it's with the idea, rightly or wrongly, right or wrong, that it may reduce the risk of bleeding, but we may be underappreciating the risks posed by the blood product, risks that, as Jeannie and Alex said, we don't fully understand, but the signal of harm that remains unexplained and may have to do with a whole slew of inflammatory reactions or whatever so the point about using mortality as the endpoint is to have the final most important evaluation criterion that puts in balance both the alleged benefits, but also the now better acknowledged harms of the transfusions. So if you end up having anyway, so that's the reason for the mortality endpoint. Obviously, all these other things are getting measured as well. So transfusion reactions independently, so the harm signal is going to be looked at independently, the bleeding signal is going to be looked at independently. But ultimately, if all you do is change the risk of hematomas, because in the PACER trial, a lot of people have commented on the severity of the bleeding, right? And if you're having minor bleedings that are controlled with pressure, and that's the only benefit you're achieving, meanwhile exposing patients to something that's costly and potentially harm, then maybe that's not guiding clinical decisions in the most appropriate way. So that's kind of the underlying idea for this overarching mortality endpoint. Anyone want to add something? This is my
I would just add that in Planet 2, when they did that trial, they had no clue that they were going to see that signal. Like same thing with patch. Like, everybody thought that platelet transfusions there was just benefit. And so I think we don't fully understand the safety of platelet transfusions. I think we've kind of grandfathered them in, that they're fine. They have these rare cytokine inflammatory fevers associated with them, some allergic reactions. But we don't know that.
I was going to add, Johnny, I think mortality is a high bar for this trial for sure, and at the same time very courageous for a trial like this. And it's not conventional, but it certainly captures kind of the totality of the risks potentially associated with transfusion, plus the benefits, I guess, when we look at other things like bleeding. So you're right. It's unconventional and kind of high risk, but potentially high rewards in terms of a trial. And I think had it been done any other way, like Francois was mentioning, if bleeding was the only outcome, it would have been criticized probably even more strictly too. So it's the best, I think, approach in a very tricky trial situation.
Yeah, I'll just add that the major bleeding complications will be captured as a secondary outcome. Um, 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 so I think the way the trial is interpreted obviously depends on where this lands in terms of the mortality, primary outcome, and all the secondaries for sure. Um, Maybe we'll go to Jacob for another question.
Yeah, I mean, I really appreciate Johnny's question and the discussion around that. I would just emphasize again as well the the arguments made for more aggressive platelet interventions here at UHN are for things like hematomas. They worry about pocket hematomas forming, then become a locus for infection, and then somebody who's supposed to be getting their chemo has to wait, and there's all this kind of so I think as long as those outcomes are in there somewhere and recorded, it probably doesn't matter as much to me, I guess, what's primary or secondary, as long as we're just capturing the stuff that the clinicians themselves are making their decisions on. My question, though, is, we talked a bit about the challenges of addressing the heterogeneity in the operators doing the procedure. Oh, sorry, I just lost my video. Now I'm back. Back in a weird angle. Anyway, uh, do we need to worry about the heterogeneity in the products? Are we sure that we have equivalent hemostatic capacity for pathogen inactivated, non-pathogen inactivated, different ages of products, apheresis, pooled, ABO group? Is that something we should be paying attention to as well, or can we just assume that a platelet is a platelet?
Maybe Jeannie or Donnie want to take that one.
I think your question about operator dependence is really important and certainly will be, has been a feature of some of the other trials we talked about. And we mentioned that even in some of the discussion that Alex had brought up. So that will, be an important part of interpreting these results. But I think, generally the types of procedures that are going to be captured by this trial are going to be, you know, fairly uniform. Okay, so there'll be some heterogeneity within the procedure types, but as you've seen on some of the reports already, the vast majority are going to be central venous catheter insertions. And by and large, the process for putting those in are going to be fairly standard. So I think that's going to be okay. But certainly, you know, operator skill level is always going to be a feature in some of these considerations.
Jacob, for the, pathogen reduced versus the other, types of platelets, this is a great opportunity for like a sub-study because you're going to have like whole countries, like, you know, everybody supplied by Canadian Blood Services is currently getting a pathogen-activated platelet in platelet additive solution mostly, but everybody in Quebec is getting apheresis non-pathogen reduced platelets. In the UK and the other countries, different criteria, like different manufacturing. So those studies should be able to be done, after the fact to look at those individual. But there are other platelet trials ongoing, and it doesn't look like they're seeing flags for differences whether you're pathogen activated, the platelets are PAS in platelet additive solution or not. So they look equivalent in the other trials that are ongoing.
If I can make just a tiny comment, if it helps you to run your study. In my world, in interventional radiology publication and trials, there are two factors that sync a study. One is patient selection, and the other is operator experience. And we have multiple examples of procedures that were being done that had negative results. And once they cleaned up the operator experience, all of a sudden it was a screaming signal towards, yeah, this is a procedure that works.
Yeah, well, I think on operator experience, the the vast majority of procedures that have led to randomization in this study that are considered low to moderate risk are central venous catheter insertions, arterial catheter insertions, and those are delivered by a wide variety of folks with different levels of training, which is sort of standard of care in the Canadian landscape, and I think probably in much of the world as well. So, um, uh, and there are procedures that are that themselves are broadly established, I would say. So, um, the we'll see what happens in the trial, I guess, as to um, whether results potentially differ by level of experience. Although I'm not sure that we're capturing uh, a lot of detail on that. Francois, did you have a comment?
I was going to say, well, the proceduralist issue is notoriously difficult to handle. One thing that's clear is that trials have to evaluate healthcare interventions the way they are delivered in the real world. And unless we are arguing that every central line and arterial line is going to be forever inserted in the interventional radiology department, that's going to be a tricky one. So that, platelet transfusions are meant to the way they're used now is the way they have to be evaluated, and it is tricky to quantify proceduralist experience, and admittedly that is a challenge. The question about the product heterogeneity is much easier to address, and this is going to be not only something that can be analyzed, in hindsight, but it's upfront being handled by randomization and more specifically by the stratification of randomization. So the type of product that patients receive is pretty homogeneous at the site level over a period of time, and by stratifying the randomization by site, even if, and it may not be the case, but even if a particular product was associated with a much higher bleeding risk than another product, that would sort of disappear the way the trial's has been handled, and will be explored in other fancy analyses thereafter. But it's sort of dealt with the randomization. The procedure the proceduralist or the expertise of the person doing the procedure, that is obviously a little bit more challenging because that might be determined before randomization or after randomization, and the actual threshold might impact who is going to end up doing the procedure. So there are many layers of complexities there, granted, but again, this concept that interventions, however imperfect, have to be evaluated the way they are used in the real world is kind of important, and it's the spirit in which this trial was designed and is being rolled out.
Thank you.
Great, thanks. I think we just have a couple minutes left. So, Donnie?
Just in 30 seconds or so, if I could just think about a takeaway message from today's talk. Certainly we heard that probably we're over transfusing platelets given the lack of data. However, there still is equipoise to know which is best practice. And so many of you are part of the T4P trial and will be participating at your sites. There will be potentially some deviation from normal practice based on the trial, depending on which randomization patients are allocated to, or which area intervention patients are allocated to. But without doing the trial, we will never really know how to best address this question. So, I'm encouraging you to reach out to, the blood bank folks or the intensive care folks who are involved in the trial to maybe talk about these things as they pertain to your site or how to roll it out. There have been lots of experience with other sites who've done this very successfully. So I encourage you to kind of reach out to us and we can help you move that forward at your sites if needed.
Thanks very much, Donnie. And just to echo that, like very appreciative of time taken by Jeannie and Alex to discuss their perspectives on this question. And I just to further what Donnie said, we're also very appreciative of all the actual and potential sites online here. And just to emphasize what both of our speakers highlighted was that was the low to very low certainty evidence for essentially all of the recommendations on platelet transfusion thresholds. We really hope that this international trial will go a long way towards answering this particular aspect of platelet transfusion medicine, which is when to transfuse in the context of a low to moderate bleeding risk procedure. And please feel free to contact any of us. Marie-Hélène Masse is the trial manager, but Francois, myself, Donnie, Jeannie are happy to take questions by email or to schedule follow-up discussions. And we really look forward to be working with everyone on this trial over the next couple of years. Thanks.